So, MYKOLA, you can see my screen, all of you? I hope
Yes,
so.
yes,
Okay.
perfect.
So I'm just
Now,
gonna.
just a second. Now I need to introduce you for all audience because that's a little bit
Yeah.
different from. So, ladies and gentlemen, here's a wonderful day today because we have an opportunity to hear from two brilliant lectures, and I want to appreciate Sona-Pharm company for this opportunity and for this organization. And the first lecture is a well-known specialist in IVF and reproductive endocrinology, well-known scientist and a lecturer and IVF specialist, and a man who was at the very beginning of the many processes in IVF, triggering these agonists, luteal phase support in this case, and many other things. And today, I want to hear from you, Peter, your ideas about the search for the most optimal frozen embryo transfer protocol, which is still continues. So the floor is yours. Peter, Mike.
Dear MYKOLA and dear colleagues everywhere, thank you very much. I'm very happy that you gave me this opportunity to give a lecture on a very interesting issue, the whole idea of which FET protocol is actually the most beneficial for the patient, for the child, and do we have specific cutoff levels which we need to respect. My disclosure slide. Now, when we talk about luteal phase, we need to go into basic endocrinology. And here, of course, what we are talking about is the luteal phase, or rather the mid-luteal phase. And what I want you to observe, we all know that obviously this is the stage in which progesterone reaches its peak, its LH plus 7. But also note that actually there is also a peak of estradiol. I'm going to go into this a little bit later in my lecture because we are all now focusing on the peak of progesterone around implantation. So this is where the embryo implants, and this is obviously why the beneficial effects of progesterone play the most important role around peri-implantation. Now, so what are the effects of progesterone? Well, we all know that progesterone will transform the endometrium into the secretory phase and open the so-called window of implantation. But you know, the window of implantation is not very well defined. And it also differs from patient to patient and actually also within the same patient. Another important issue of progesterone is that it increases endometrial vascularization around the implanting embryo to secure the fact that the trophoblast is well nourished once it implants. Now, another thing which I think probably most of you do not know is that progesterone plays a very important immunomodulating role, not only in the, let's say, maternal-fetal interface that is locally in the uterus, but definitely also systemically. And this is why we are now focusing more and more on the fact that, yes, for many years we've believed that local, that is the vaginal, for instance, would be the most optimal. But I think more and more we realize that a combination of local and systemic probably could be even better. And the reason for this is the importance of the immunomodulating of progesterone. Another fact which we all know is obviously that progesterone reduces contractions at peri-implantation. Now, I just want to take you through this slide because, you know, we all talk about mid-luteal phase and what are the LH levels, what are the progesterone levels. This is a very nice old study from Marco Filicori, one patient during mid-luteal phase. Now, what you see, this is LH plus 8. In the upper panel, you see the LH surges, and in the lower panel, you see the progesterone surges. And what you see is that for each LH surge, quite a few minutes or a few minutes later, you will have a progesterone surge showing you how dependent corpus luteum is of LH activity. Now, this is one thing. Another thing which we see is also the huge variability in progesterone measurements in serum when you have a corpus luteum. Because progesterone is secreted in a pulsed way, this also tells you why it doesn't make sense to measure progesterone in a natural cycle. Because if you are here, you're going to be too low. If you are here, you're going to be too high. Another important thing of this patient is the fact that what is the mean progesterone level that this patient secreted during her luteal phase? Nearly 20 nanogram per ml. Please remember that the lower cutoff, which we're going to repeat many times during this lecture for frozen embryo transfer, is 10 nanogram. But this patient had 20, telling us also that the lower cutoff is definitely the lower cutoff, and maybe some of our patients would do better with higher progesterone levels. Now, how much does a corpus luteum produce daily? It produces 25 milligrams of progesterone daily, so it's a very, very intense production from this little corpus luteum. Now, in this slide, I asked the question, can we rely on the corpus luteum when we talk about natural cycle? Does the natural cycle corpus luteum always work as it should? With my colleague and others, we published this paper in which we were studying the luteal phases of 20 patients during 3 months. Now, here I just show you 2 patients, patient 1 and patient 2. On the left-hand side, you see the progesterone level. On the x-axis, you have the days. Now, 35 nanomolar is approximately 11 nanogram. So what you see here is actually just in one of these cycles, did the corpus luteum produce the lowest cutoff of progesterone, that is around 10 nanogram, whereas the 2 other cycles from that patient did not reach these levels. For patient 2, we see the same pattern. Only one reached approximately 20 nanogram, whereas all the others were very, very insufficient. So it tells you, no, we cannot rely on the corpus luteum of the natural cycle from cycle to cycle. And this is in general. These were all normal cycling ladies. So what is the lower limit for natural conception, as suggested by Michael Hall many years ago? So in this study, he was exploring a large number of patients who were completely healthy, normal cycling ladies. And what he showed was that the lower level was approximately 10 nanogram per ml, just as we suggest for frozen embryo transfer. But again, it's the lower level. Now, Birgit and I, we published a paper recently in which we were asking what are the predictors of the function of corpus luteum? Because can we predict during follicular phase how the corpus luteum is going to function during luteal phase? And yes, actually, we looked into estradiol levels, and what we saw that patients who had an estradiol level on day 10 of the follicular phase, more than nearly 90% of these patients also reached a progesterone level above 10 nanogram. So it tells you the function of the granulosa cell will repeat itself later on as the luteinization has occurred. So granulosa cell function during the early follicular phase, or late follicular phase rather, here is a good predictor of what is going to happen for this corpus luteum during luteal phase. So another issue which I think is very important is that age also plays a role for corpus luteum function. Here you see two different patient groups. Here the mean age of 27 and here the mean age of 40. And on the y-axis, you have the progesterone output. So you can see there is a significant reduction in progesterone output from the corpus luteum just induced by age. The older the patient, the lower the production of progesterone. And this is now in urine. So someone also looked into saliva, and they saw the same interesting phenomenon, that the older patients had a lower progesterone output compared to the younger patient. But for the youngest patients, Those between 18 to 19 years, you can see this was nearly as low as the oldest patient. So nature somehow put in like an OCP to avoid pregnancies in very young patients and pregnancies in very old patients. I think this is very important. Also, if you do oocyte donation in natural cycle in older patients, you cannot rely on natural cycle only. You need to add some kind of vaginal support to overcome the deficit in progesterone. So we talked about the cutoff, and in this study, which I think you know, the authors looked into nearly 300 blastocyst transfers, and they looked into natural cycle, and where they were measuring progesterone the day before frozen embryo transfer. And what they saw was that nearly 40% of these patients, natural cycle, had a progesterone level lower than 10, that is lower than the lowest cutoff. And if you look into the live birth difference between those who were optimal, above 10, versus those who were low, you can see there's a difference of 15%, 1.5. Again, these patients did not receive any luteal phase support. So this was the complete natural cycle, telling you again that nearly 40% of these cycles have a corpus luteum insufficiency. So obviously we have a meta-analysis looking into natural cycle frozen embryo transfer with or without luteal phase. And you see here that is the supported group. You see there is a significant increase in clinical pregnancy rate, but also in live birth rate if you compare those who had progesterone during natural cycle frozen embryo transfer compared to those who did not. Now, this meta-analysis is a little bit skewed because we also have retrospective studies included. But the data are very nice. And if we go to the most recent, which is just 3 years ago, we have this very nice Swedish study in nearly 500 natural cycle frozen embryo transfer. And here you can see patients were randomized to either no luteal phase support or luteal phase support. And the luteal phase support was vaginal micronized progesterone 100 milligram twice daily. And here you see the difference. So here you have the ones who were supported with luteal phase support vaginally and those who did not. So you lose approximately 10% live birth rate just by not adding luteal phase support in natural cycle. And this data fits very nicely also the Portuguese study that I showed you previously. So if we don't want to do complete natural cycle, could we do modified natural cycle, and when should we trigger? Because, I think the most of us, we have been waiting until follicles were around 17 millimeters when we do modified. Modified means using an HCG trigger. In this study, you can see 3,000 modified natural cycles. And here they were looking into the outcomes according to the follicle size on the day of the trigger. So here they were triggered very early, between 13 and 16 millimeters, here 16 to 19, and here 19 to 22. Now, the interesting thing is that if we go for the ongoing pregnancy rate, there is no significant or highly significant difference. There seems to be like a 10% difference in favor of this group. Here it seems even higher, but again, look at the numbers, 124. The vast majority were triggered at between 16 and 19 millimeters, giving a very nice ongoing pregnancy rate. But I think this group actually tells us that we can trigger earlier. And if this is easier to schedule, we can trigger at 14 and 15 millimeters in a modified natural cycle. And I think this is important message. So when do we transfer? And I'm sure you already know this. We published this paper some years ago in which we were saying, well, if we do the artificial cycle, we transfer on the 6th day of progesterone. So this is progesterone plus 5. In a true natural cycle, we would do the transfer on LH plus 6. And if we do a trigger, it's HCG plus 7. We transfer on HCG plus 7, day 7. So recently we then had a new protocol coming on board, the natural proliferative phase frozen embryo transfer. So what does this mean? Well, this is actually a combination of a natural cycle and an artificial cycle. So this protocol does not use any estradiol. So this protocol will just follow the patient until the endometrium is 7 millimeters and then completely disregard the follicle. But we all know that if you have a 7 millimeter endometrium, you're quite likely to have follicles which are between 15 and above. So on this day, they just started vaginal progesterone, 400 milligrams twice a daily, and they did transferred on the 5th day of progesterone. You know, you can transfer on the 6th, on the 5th. There's no difference if it's the blastocyst transfer we talk about. So here you combine the natural cycle in terms of you don't add any estradiol because you just let the follicle produce the estradiol. And once the endometrium is thick enough, you then convert this into an artificial cycle, obviously again to make scheduling easier. But the benefit of this protocol compared to the artificial is that you will have a small corpus luteum with this protocol, which produces a little bit of progesterone, a little bit of estradiol, but also relaxin. Remember, in the artificial cycle, we still see like more preeclampsia, so the double the rate of preeclampsia in artificial cycle compared to true natural cycle and modified natural cycle. And we suggest that the reason for this is that we don't have relaxin, which has a very important impact on the vessels of the patient. So again, a new paper comparing now the artificial cycle to this new protocol to complete natural cycle. And what they wanted to look into, this is a cohort, so it's not randomized, but you can see the numbers are large, especially for artificial and for natural cycle. Now, if we look into live birth rate, you can see that the new protocol actually is very much similar to the complete natural cycle. But in terms of the artificial cycle, the live birth rate here was lower, so significantly lower, again, approximately 10% lower compared to the NPP protocol, and here again, approximately 8% lower compared to the natural cycle. So actually in favor of the NPP and natural cycle. And if we look into miscarriage rate, we see the usual pattern that the miscarriage rate is quite high in artificial early miscarriage compared to the new NPP protocol, and again compared to natural cycle. So what about bleeding? Again, I think we all know in natural cycle we have quite a lot of bleeding. Birgit Asbjerg and I published a paper showing more or less these results, that 40% of our patients experience some kind of spotting or small bleedings or brownish fluid, which obviously makes them nervous. But it has no impact on the live birth rate. We were able to show this, but obviously it's annoying for the patients. If we compare the protocols with the corpus luteum, you can see that the bleeding is significantly less. Now let's go to hypertension, because the preeclampsia, etc., obviously was what we wanted to avoid, having a corpus luteum around. And again, we see a significantly higher rate of gestational hypertensive disorders. So not only preeclampsia, but at least hypertension in those patients who had an artificial treatment compared to those who had a corpus luteum around. Here they were quite similar. Now, you could ask, okay, we measure progesterone in serum, but this is just a proxy of what's going on in the uterus. Is this actually an indicator? Can we use serum as a measurement of what goes on in the uterus? And for this purpose, a very nice study in volunteer patients. You can see here 5 groups of patients who were treated differently. So the idea was a long agonist downregulation. This is what the Americans do for their frozen embryo transfer. Then oral estradiol for 10 days, and then they used progesterone IM in varying doses. And then they took a biopsy on day 10 of progesterone, an endometrial biopsy. And here you see patients who had the 40 milligram daily, the 10 milligram daily, the 5 milligram, and the 2.5 milligram daily. And you see that obviously just after you inject, a few hours after the injection, you can see on the y-axis progesterone is close to 18 nanogram per ml. And when later on the day after this 40 milligram injection, we reach around 10 nanogram per ml. And the less we use, obviously, the lower the peak and the lower the trough. Now, let's look into the biopsies. And I think we all agree that all biopsies, 40, 10, 5 milligram, they are in the secretory phase. So if you ask the histologist, he will tell you that this endometrium is receptive. The only one which is not in the secretory phase is the 2.5 milligram. So this is what we would know from histology. But now we are 2025, and we cannot just rely on very old-fashioned histology. We need to go into gene expression, and this is what the authors did. What they saw here was that the only gene expression pattern which was similar to controls who did natural cycle, complete natural cycle, were the patients who had the 40 milligram. The others also had a gene expression which was close to, but not similar to natural cycle, telling you that yes, the serum levels will give us a very nice prediction of the gene expression pattern going on in the uterus, in the endometrium, and this is why we can use it as a predictor. Now, how much progesterone do we need for the window of implantation? And is there a difference in the window of implantation and the early implant? Because we don't just want the embryo to implant. We want it to continue, not just to become a biochemical pregnancies. And there would probably be differences. This has not been completely, let's say, explored, but we all know of these patients who had repeat early pregnancy losses. We also know that one of the best treatments for repeat early pregnancy loss is let's say in a patient who conceives spontaneously, is to add progesterone. So one thing is the implantation, and the next thing is how to add more progesterone to secure the growth of the early implant. And obviously this is a very complex process involving VEGF and HCG and prostaglandins and progesterone and a lot of factors, the whole implantation process. But we all know now that we have cutoff levels for frozen embryo transfer, which are suggested. And here just some of the studies, including our own. And you could say, but come on, Peter, someone says 11, someone says 8.8. But I think we should just say we have to know that these studies use different analysis, and I think the only study which actually standardized blood sampling was ours, because as I showed you for the Americans, if you measure very early to vaginal support, just like IM support, you're going to have a very high progesterone level. So you need to do this in a standardized way. And this is why you get these small differences. But what you can see is that everyone agrees that if you are lower than these cutoffs, you lose between 14 and 18% ongoing pregnancy rate or live birth rate. And let's just keep simple. Let's just go back to nature, because this is what Michael Hull taught us many years ago. 10 nanogram is what nature wants. And this is what we should also respect when we do our frozen embryo transfer. But it's the lower cutoff. And you could say, so what is the higher cutoff in which you start having negative? Because nature is always too little and too much is not very good. And there are just 2 studies looking into this, both retrospective analysis, and they actually both suggest that the upper cutoff is 32 nanogram per ml. 32. So it just tells you there's a wide range here from 10 to 32. So maybe, and this is my suggestion, some of our patients would do better being above 10 compared to be very close to 10. Now, for some years, we've had a specific interest in endometriosis, adenomyosis, because we were saying, okay, 10 nanogram is the lowest, but does this apply to endometriosis, adenomyosis patients? What we know from Serdar Bulun, who is a basic physiologist who did a lot of research in endometriosis as well as adenomyosis, we know that for both patient types, the pattern is the same. They have an excessive local estrogen biosynthesis in the endometrium. And as you know, estradiol is the most pro-inflammatory steroid that you have around. So with very high estradiol levels, you will activate prostaglandins and cytokines in the endometrium, and downstream, this will induce a progesterone receptor resistance, telling you that endometriosis, adenomyosis, probably you need more progesterone to have a fully functioning endometrium. This is the basic physiologist. This is what they told us. And we also commented on this, saying, yes, we definitely agree. And we were saying it's just like the switch is difficult to turn on. You need more pressure, more progesterone to turn this switch on. And we were then saying this is why we should never transfer fresh in adenomyosis, endometriosis, because remember, when we stimulate our patients, we have very high systemic estradiol levels, but also local in the endometrium, we increase estradiol. And if you have a patient with adenomyosis, endometriosis, she has already got progesterone resistance. If we then stimulate her further, we're going to increase the estradiol level in the endometrium and further increase her progesterone resistance. And this is why in this paper we said we definitely suggest a freeze-all for endometriosis, adenomyosis, and then frozen embryo transfer. So always segmentation, first stimulation, then segmentation. And I know that our French colleagues from the unit of Chapon, who are specialists in endometriosis, they also never do fresh transfer any longer. So we stopped doing fresh transfer 7 years ago, and we had a lot of patients who previously failed or had biochemical pregnancies during their fresh transfer who finally conceived. So I also mentioned adenomyosis, and adenomyosis is something that we fertility specialists really need to look into, to open our eyes for. I think until now, a lot of us have just neglected these findings, but they play a very important role for the receptivity and the capacity of the endometrium. In this analysis from an IVF unit in Spain, you can see the prevalence of adenomyosis in more than 1,000 patients was 1 in 4, so 24%, very high. So every fourth patient you would see would have some kind of adenomyosis. Another thing is that those patients who did not have implantations, the repeat implantation failures, here the prevalence is around 35% of the patients. And even worse, for those patients with early pregnancy loss, the combination of early pregnancy loss and of adenomyosis is nearly 40% of the patients. And this, I think, for many of our colleagues has been completely neglected. Another thing is that if you have a patient with endometriosis, 25% of these patients will have adenomyosis and vice versa. So how do we classify? Well, I'll have to refer you to this excellent paper on the so-called MUSA criteria, the stratification of ultrasound findings of adenomyosis, and they classify these patients into direct features and indirect features. The direct features are the cysts, the myometrial cysts, the hyperechogenic islands, budding, and then we have the indirect features which are usually asymmetrical thickening between the anterior and posterior wall, or the other way around. Translesional vascularity, so here where you have the islands, if you put the Doppler there, you will see this typical translesional vascularity. We also have shadowing, because there are a lot of small fibrotic areas, so you get this fan-shaped shadowing. Finally, if you looked into the JC zone, the junctional zone, in some patients, you will see that it's interrupted or very irregular. So these are important findings that we need to concentrate on when we scan our patients. Here, just to show you, here you have the asymmetry between the anterior and the posterior wall. You have the hyperechogenic islands. You have the fan-shaped shadowing. Here, a very clear example of budding. That is, you can see how the endometrium grows down into the myometrium, sends down a small bud there. Myometrial cysts, as shown here. And if we go for the JC zone, you see this typical, very irregular endometrial JC zone, and here also very thin here, and then suddenly we have this irregularity. We also have the hyperechogenic cloudy areas here. So very, very frequent finding in patients. And what disposes to adenomyosis? Well, previous C-section, previous birth, previous curettage, and then obviously again, the older you get, the higher the risk of adenomyosis, because adenomyosis, this is the theory, is also induced by the fact that by every menses you have the risk of having a small, let's say that the basal layer of the endometrium, which is not discarded, will grow into the myometrium. And the more menses you have had, the higher the risk of this. So the prevalence in a young patient is around 25%, and in an older patient, it's 29%. And never forget, we all have these patients who had no problems of conceiving for their first child, and then they have like 3 or 4 years, maybe a few biochemical pregnancies or missed abortions. Finally, you see them. Usually we would say, oh, second child is piece of cake. But for me, I now see more and more adenomyosis as a reason for why these patients did not conceive with their second child. And can we do something about it? Well, I'm going to show you later. So you have to consider endometriosis as brother and sister, because the basic physiology, the basic impact is increased estradiol in the endometrium in both patients. Now, just wanted to show you some differences. Here, it's an Italian study. You see, they looked into 101 endometriosis versus 100 non-endometriosis patient. In red, you have the endometriosis compared to the non-endometriosis. Here you see the number of embryo transfer and your cumulative live birth rate. Nearly for all stages, the endometriosis patient performs worse. Another study, this is now from China, and here they had 225 endometriosis patients versus 697 non-endometriosis patients undergoing frozen embryo transfer. This is artificial cycle. And what do we see here? Well, you see there's a 10% lower difference. Live birth rate is 10% lower in the endometriosis compared to the non-endometriosis patient. And obviously, the cumulative live birth rate also gets significantly lower. So there is something here that we could look for. And I just ask you to remember the 34% live birth rate, because I'm going to go into this in a minute. So 34% live birth rate in endometriosis artificial cycle. So we asked ourselves, okay, if we have resistance to progesterone resistance in the endometrium, does this mean that the cutoff of progesterone is higher in endometriosis? We asked first in endometriosis, but I can assure you we use exactly the same idea for adenomyosis, and it is higher. Now let's go for the study that we did. So we had 262 artificial cycle frozen embryo transfer in endometriosis patients. Now, in those days, we already decided we're never going to do a fresh transfer, and we're going to treat these patients pre-treatment prior to transfer. So what you can see we used in those days, we used the oral contraceptive pill for 6 weeks to downregulate systemic estradiol. Then we had a 5-day washout. Then we did the standard priming with estradiol, and we, as for progesterone, we used vaginal progesterone, but on the 4th day, we added IM progesterone. And you could say, what is this? Why do you want to do this? Well, we wanted to mimic what's going on in natural cycle. So we wanted to start off with vaginal, and then around peri-implantation, that is 2 days prior to transfer, we would then boost with some more IM progesterone. This was the whole idea. And then again, we transferred on the 6th day of progesterone. Now, what did we see? We looked into progesterone levels, and everything was done in a standardized way. So we measured progesterone on the day of the transfer. So what we saw that there was actually a cutoff, and we used a statistical model called the Odense index to find in an objective way the cutoff. And what we saw was that the cutoff was significantly higher compared to non-endometriosis patients. You can see it's nearly 40 nanogram per ml. So if you were above 40 nanogram per ml, the live birth rate was 51%. If you were lower, it was 34% in endometriosis frozen embryo transfer. And you can see the difference is 17%, which is high. Now let's just go back, and it tells us that there is progesterone resistance. We need higher progesterone levels. Now let's just go back to that Chinese study. Look at this, 34 and 34. By having higher levels, we significantly increase the live birth rate. So the whole issue of adenomyosis for me is very interesting. It's pioneering days. There's a lot to be learned. And for this reason, we had this workshop group meeting last year in Lugano. And you can see some very famous guys there. So we have basic physiologists, we have ultrasound people, we have MR people, we have IVF doctors, Juan Garcia Velasco, and our friend from France, and here from Emirates, etc. You know them by face. Anyway, we had a 1.5 day meeting. The whole idea was to bridge basic pathophysiology to ultrasound and MRI to clinical handling, because these guys are very good at finding the adenomyosis, but we have been very bad at taking care of it. We've just been treating these patients like we would treat everyone else. And I'd like to refer you to this white paper in RBMO. It's an open access paper in which we actually debate the whole issue of adenomyosis, also the close correlation to endometriosis, and the fact that they have the same pathophysiology. So should we monitor serum progesterone? I think this is quite obvious that we should. This is just one of the studies. This is from Elena, and in her hands, you can see that she was showing that if you were less than 8.8 in her hands, which was 1/3 of the patients, you lost 16%. So look at it. We lose around 12, 14, 16, 18% live birth rate if we are too low. Remember, this is now non-endometriosis, non-adenomyosis. This is standard patient. So what if the patient is too low on the day of the blastocyst transfer or the day before? Well, here, 220 PGTA cycles, it's artificial cycle. And here in this setting, they transfer on day 5 of progesterone. So they asked the patients to come on day 4 for a serum measurement. And what they saw was that quite a nice proportion, nearly half of the patients, had a cutoff lower than 10 nanogram. And for these patients, they decided from day 4, that is the day they had the blood sample and they had the measurement, to add 25 milligrams of progesterone subcutaneously daily. And let's see what this did to the live birth rate. Well, in orange, you had those who had the 25 milligram, and in blue, you had the controls who were above 10.6, and you can see that there is no significant difference in any parameter, live birth rate, miscarriage rate, which are obviously the most important parameters here. So yes, you can rescue one day before. In this paper, which I co-authored, we rescued from day 5, that is here in this setting, they transfer on day 6 of progesterone. So again, patients needed to go to the unit one day before to have measurements, and then we added 25 milligrams of progesterone, and for the rest of that cycle, 1 injection daily. And again, you see the rescue group here. This is now ongoing pregnancy, 50% versus the control group, no difference. So yes, you can rescue. So these studies that I showed you until now were rescuing with subcute progesterone, but could we do it in a different way? What about the rectum? We use the rectal route for many other medications, and it's an excellent absorbent of medications. So we wanted to try this here. And this is now, again, standard patients, so they are not endometriosis, not adenomyosis. So this was our HRT regimen. It's still more or less the same. 6 milligrams of estradiol, followed by micronized vaginal progesterone, 400 milligram twice daily. What we saw using this type of progesterone, we saw that 23% were less than the 11, let's say less than 1110 nanogram, 23% on the day of embryo transfer. So we measured, or this is what we still do, we measure the progesterone on the day of the transfer. This is day 6 in our hands. In the morning, standardized, 2 to 4 hours after the latest vaginal application. And then we do the transfer, and we will have the results of the progesterone in the afternoon. And in patients who are less than 11 nanogram per ml or 35 nanomolar per liter, these patients are asked to add 2 rectal per day. So this is what we call the 2+2 rectal, 2+2 regimen. So 2 vaginal and 2 rectal. And we use this route quite a lot. And the idea is then, okay, does this help? Do we rescue? Because here we change 2 things. We rescue on the day of the transfer, and we use the rectal route. So just to show you here, you have the 2+2 regimen. Here you have those patients who had a sufficiently high level. And if we go again for ongoing, which is very close to live birth rate, there's no difference. So the answer is yes, the rectal route works excellently well, and we can rescue on the same day as of the transfer, so that we don't need patients to come back to our unit one day before the transfer. Now, I just want to confuse you a little bit, because biology is complicated. And when I started, I was saying, well, please remember that we also have a mid-luteal surge of estradiol, which I think most of us until now have disregarded. But in this study, and these were all artificial cycle, more than 400 cycles, we were correlating the live birth rate to estrogen levels. So we only used patients who had normal progesterone levels above 11 or 10 nanogram, and then we looked into their estrogen level on that same day. And here we saw a significant correlation between estrogen levels and the live birth rate. So if you are too low, here in this, we lost 20% live birth rate, and even more if you're too high. Now, this is the first study looking directly into this issue. We need more studies, but it just tells you that obviously from the side of nature, estradiol also plays a role. The next question is, do we measure estradiol regularly the same way as we measure progesterone now in our daily work? No, we don't, because for progesterone, we will have the answer in a few hours. For estradiol, it's going to take us a significantly longer time in the lab, which does the analysis. So we do it for research purposes, but we don't do it on a regular basis. You can see the cutoff here. It's between 300 and 400 picogram per ml seems to be the optimal level. And this is if you go for this is picomolar. This is now picogram per ml. If you go for picomolar, it's between 1,000 and 1,500 picomolar, the optimal range. But again, we need more studies supporting what we found. So we all use a lot of vaginal progesterone. And what could we actually expect from a standard vaginal progesterone regimen if we use different vaginal compounds? And again, here, we just have to realize, and this paper is actually already published, it says in press, but you can find it in PubMed. What we were able to show is that if you look on this side, you can see we never get higher than at its best 14 nanogram or 15 nanogram per ml in these studies in serum. Remember, the lower is 10, the upper seems to be 32. So with the vaginal, we circulate between here 9, 12, 13 and 14 nanogram per ml. And the important thing also is that there are significant differences between different preparations. Here, luteolus, here, cyclogest. Cyclogest, a significantly higher serum level compared to luteolus. So not only do we need to look into the concentration, which is in the progesterone, but also the way this was prepared, whether this was in an aqueous formation like luteolus, or whether this is like a fatty emulgation, which it is for cyclogests, plays a role. Another important thing, and this is if you want to increase for some reason the serum progesterone, it doesn't help to add more vaginal, because you will not, we tried this also in studies, you're not going to increase. There is like an upper limit for what a vagina can resorb. So you need to change the route. So either subcute, rectal, or maybe oral. We don't have oral in Denmark, but probably you do. But oral can definitely also be used. The only thing is for oral, we cannot measure the impact of oral because we cannot measure the compound in serum. I just wanted to show you this one because I think this is something which is important for all clinicians to know. What does the serum concentration, this is picogram, so not nanogram, but picogram per ml look like using different preparations? Here you see the subcute. So again, showing you that just half an hour after you applied the subcute, it gets very high. It's now nearly 75 nanogram per ml. And then 4 hours later, it's 20. And then it goes back to around 18 nanogram. And then this is why if you want to use subcute for full luteal phase support, not just as an adjunct, then definitely you need 2 injections per day if you wanted to use it full. Now, if we compare with the IM, you can see the IM reaches its peak around 4 hours after the application, and then slowly it goes down. Now, in this study, they did a comparison between the area under the curve of progesterone of IM versus subcute, and there's no difference. If we go for the vaginal, you can see we are still, if we just use the vaginal route, we are quite low. Here at its best, initially it's around 20, but then later on in the day, you can see we now go less than 10 nanogram per ml. So the way we administer definitely plays a role for serum levels. which we need to take into account. It also shows you, this is why you need to standardize your blood, your serum measurements. Here, for vaginal, you reach your peak between 2 to 4 hours after, and this is why we standardize, when we use vaginal only, we standardize to 2 to 4 hours after the latest vaginal, because if we do it too early, it's going to be very low. If we do it too late, it's going to be low also. So just to conclude, well, I definitely believe that we should monitor mid-luteal progesterone levels, because if we don't, we lose between 12 and 16% live birth rate. Now, this is what we're doing in frozen. Later on, we will be doing the same thing in fresh, I'm quite sure. We did the initial studies in 2018 showing also this typical bell-shaped curve, either too low or too high. But until now, I think the majority of our colleagues are working only in frozen embryo transfer. And when you do this, yes, standardization, the assay that you use, it's not necessarily the same assay you have as Elena Labata in Spain. Please also remember the differences in the products due to how they were prepared, in which media they were prepared, and also patient-to-patient variation. So weight plays a significant impact. Age also plays an impact. So the more obese the patient, the lower the serum levels. But the older the patient, actually, the higher the serum levels, because if it's like a postmenopausal lady and you're doing egg donation, well, the lining of the vagina is more atrophic, and this is why it's thinner, and this is why the absorption is higher. So let's just finalize to say, well, I think I gave you sufficient evidence to show you that the lower cutoff of progesterone is 10 nanogram per ml, which is very close to what we see in nature. And we now suggest, and this is the first study showing, we suggest that for endometriosis, we should be at nearly 4 endometriosis and adenomyosis, I should add. We suggest that we should be nearly 4 times higher according to those data. Again, others are going to repeat it and see whether they can find the same issue. Then we had this NPP protocol, which is a combination of natural and artificial, but which secures the function of a corpus luteum, is interesting. But we also have the modified natural cycle, in which we can just trigger a little bit earlier than we used to do if we want to be sure to avoid weekend transfers. Again, I'm still searching. We are refining it. We are getting better and better. Please remember, 10 years ago, we were losing all these pregnancies because we didn't do the monitoring. Now we gain, and probably there will be more to gain. So progesterone is definitely the key to success. I think we learned a lot from the agonist trigger, which actually put our eyes on the luteal phase. We opened it, we learned a lot, but there's probably still more to be learned. And again, one size does not fit all when we talk about progesterone supplementation. And I thank you all for attending this lecture. So,
thank you, Peter, for your brilliant presentation. Now we have some time for Q&A session, and I already have some questions for you. And the first question is, considering that luteal phase progesterone levels decline with advancing age, which protocol should be the most appropriate for the advanced stage patient? If we are thinking about the physiological changes and conditions in progesterone levels and that kind of patient.
And MYKOLA, this is a very good question, but I don't think anyone, focused on age only. But I think, to me, more and more the modified natural cycle comes in line, because there is a very nice study from Copenhagen, which is coming out now, showing that if you use modified natural cycle with or without luteal phase support, there's no difference in live birth rate, because the HCG really boosts the corpus luteum to its best. So it seems that modified natural cycle is actually a very good option. It's got a good flexibility. We can trigger earlier. We secure a functioning corpus luteum, and according to this new data, we don't need any additional luteal phase support. But again, for the very, let's say, the more aging patients, I would still probably go there. Yeah, this is where I would go, because I want a corpus luteum, because these patients are also at risk of hypertensive disorders and preeclampsia with age. So I would definitely go to some protocol which ends up with a corpus luteum. So either the modified natural cycle with luteal phase support, or the NPP, the new protocol, the combination of natural and artificial. So we have.
Yeah, it's a very clear idea that the crucial part of the luteal phase support is corpus luteum, which is producing not only progesterone but relaxin. So, and that's why we have much better outcomes after the cycles with relaxin and with corpus luteum, comparing to the absolutely unnatural artificial cycles. So that's very clear idea. But if not all our patient has the ovulation and follicle. So in case our patient does not have follicle, what do you prefer? So do you move to the ovulation induction for embryo transfer?
MYKOLA, obviously, I need to be very honest with you. Now, still here, 90% of our cycles are artificial, because this is where we did all our research, but also because I think, there is a hype against artificial cycle by people who say, well, it's very dangerous and preeclampsia. Yes, but I'd like to refer you to a very nice review paper, open access, Human Reproduction, by our colleague Polytsos, in which he debates, is artificial cycle dead? It's not dead. And if you look into the prevalence of preeclampsia, it's 3 out of 100. 3 out of 100. I think when we have the debate with the protagonists of everything back to nature, etc., it sounds as if, everyone is going to have preeclampsia. So definitely we can also use the artificial cycle, yes. And we still use it a lot.
Thank you. That's a really nice point. So to change the practice, we need time, not only evidence. So it's impossible to switch it just in one day, even if you have a very good evidence. So.
Exactly. And I would say it's not a crime to do an artificial cycle. Definitely not. And again, we're talking of, we want to avoid preeclampsia. Obviously, we want to avoid it. But what many of these studies did not take into account were all the other risk factors like obesity, hypertension, diabetes, etc., which obviously also would increase. So you could say for this type of patient, maybe it's more, we have to stratify. A patient with these complications, okay, we would say, well, I want a corpus luteum here. So how can I get a corpus luteum? If I can't, can we then treat these patients with aspirin, like we do with our egg donation patients, to reduce the risk of hypertensive disorders? This has not been studied, as far as I know, in ART. It's been studied in previous preeclampsia in non-ART patients, but this is an option also that we could try. Early onset aspirin, 150 milligrams daily, let's say from day 10 or something like this. This is what I would consider.
Sure, that's an option, definitely. So the next very, very practical question. In NPP frozen embryo transfer cycles, it's a little bit strange for our auditorium to transfer on the day 5 progesterone, because in our feeling, and also in my feeling, it should be a little bit later on the day 6 or even on the day 7, according to the physiology of stimulated cycles.
But
put it to the
No, MYKOLA, you're completely right, but there are actually studies even from Copenhagen looking into day 5 progesterone versus day 6, and there's no difference. Obviously, because the blastocyst does not implant on day 5 in a day 5 transfer. It implants 3 days later. Even for day 6, it's 3 days later. So this is why it gives us a wide range, but you can transfer on day 5, day 6, and I think even from Brussels they tried transferring day 7, also looks quite nice. So there is a high degree of flexibility. We transfer on day 6 like you do.
Oh, great. So day 6 also can
Yeah.
be used again.
Yeah, definitely.
And in our practice, sometimes even then day 7. So
Yeah. So we count the first day of progesterone as 0, and then 1, 2, 3, 4, 5 makes 6 days. Yeah.
Sure. So thank you. And the next question. So should the approach to endometrial preparation for frozen embryo transfers be modified in patients with endometriosis, especially in adenomyosis?
Yeah, this is what
And
we do. And this is really something I'm burning for now, and we do it. We do it. So what we do now, and this is also according to we had an the good thing is if you talk to the basic physiologist people, they will all tell you the issue of progesterone resistance. And I gave a talk at ESHRE this year with Linda Judis, who is a super specialist, has been using all her life to look into progesterone and receptors. And she was saying, I wish we had some clinical studies looking into what we see as progesterone resistance, and we have them. And what we do in our daily practical hands is that in, let's say, moderate to severe adenomyosis or endometriosis, we would downregulate patients with a long agonist protocol for 6 weeks. So we now suppress the systemic, but we also want to get rid of the local. And how do we do this? By adding letrozole. So it's like the package is 6 weeks in total of long agonist. And 3 of the 6 weeks, the last 3 weeks, we add 5 milligrams of letrozole daily. This is the priming period. So for an adenomyosis endometriosis patient, we prime her 6 weeks prior to we start the artificial cycle. Obviously, here we need the artificial cycle. So this is only artificial cycle. So a priming period, and then for the luteal phase support, because what we do here, we now reduce systemic estradiol with the long agonist, and with the letrozole we reduce the local, because in these patients, endometriosis, adenomyosis, they have an increased aromatase activity in the endometrium. We suppress it. So we now are very low in estradiol. So this is what the Americans do only, and then they do artificial cycle. What we do in our hands, we do this also, and then we actually also add more progesterone during the protocol than we would usually do. So we would use a combination of vaginal and subcute for luteal phase support. And then we measure again, and we want the levels to be about, let's say, close to 40 nanogram per ml. So this is how it works in our hands.
So 2 components.
I just wanted to tell you that it's not accepted, but we submitted from US, Italy, and my center. We compiled data from 60 adenomyosis and or endometriosis patients using this type of protocol, comparing the results, the live birth rate from one trial with this new protocol compared to all the other trials the patients underwent, because some of them had a lot of failures, either pregnancy loss or implantation failure. The chance of live birth was 30 times, 30, higher with this new protocol. So for me, it looks great. And I think it's going to be the protocol in the future. But until now, we just, we collect all the data we have in our unit, and hopefully when this paper is out, there will be more focus, and we will be able to gather even more patients. So 30 times, not 3 times, 30 times higher.
No, it's clear.
Yeah.
But additional question about this group of patients. Did you choose them according to the strict MUSA criteria? So, I mean, that was severe adenomyosis with...
You are right, MYKOLA. Again, because then we all need training. The problem is, even the MUSA criteria do not come up with exact criteria for mild, moderate, or severe. But our friend from Italy, Cozzolino, who is my collaborator and who also provided patients, he was looking into patients, and he was seeing that those patients who had these hyperechogenic, the closer you get to the endometrium, to the junctional zone, the worse the impact. And also mural cysts close to the lining is a negative impact, but specifically those white cloudy areas, they are the ones who are, let's say, most at risk. But for me, I think, okay, the patients we see, they come here for one reason: they are infertile. Usually they tried a lot at home, so they have a problem. And if they also have symptoms in terms of, the symptoms are typically dysmenorrhea, it's hypermenorrhea, and it's dyspareunia. If they are symptomatic and I see, let's say, clear signs, well, I classify them as adenomyosis. But you're right, in future we need classification systems, and we need, because we also know that we have ladies who give birth who also have adenomyosis. So it's not like strict, but for me, the patients I see, they are here for one reason: they are infertile. They couldn't succeed at home. And the typical is very often that they had either no pregnancies or a few early pregnancy losses. I saw quite a few patients who came for second child. The first child was spontaneous, no problems. And then they had 1 or 2 early pregnancy losses. So they came here and they had adenomyosis. So their problem was not becoming pregnant. The problem was to maintain pregnancy. And this is just, anecdotal. But what I decided to do was I said, okay, next time you are pregnant, the first day with a positive pregnancy test, you start with an intensive luteal phase support. So you use vaginal 400 milligrams twice a day, and you use subcute, or rather, yeah, and you use, no, sorry, I told these patients to use the 2+2 regimen. So 2 vaginal, 2 rectal, as soon as the test was positive. And these were 6 patients, and they are all ongoing.
So the main idea that patients with severe adenomyosis or just severe symptomatic endometriosis could be in need of the higher doses of progesterone, so because of the sensitivity to progesterone. But which pathological conditions, apart from adenomyosis and endometriosis, may reduce endometriosis and endometrial sensitivity to progesterone? What do you think?
No, I don't know. I can't answer this question because I think these two conditions are those who have been really really studied a lot, because over the years it was suggested, well, these patients don't become pregnant or they have early pregnancy loss because of a lower oocyte quality, which is not true. The quality is the same. It's the receptor, or it's the organ which should receive the eggs, which is impacted. But I don't know of any other conditions, MYKOLA, which have been studied the same way as this.
Yes, I'm just curious. So, Peter, thank you so much. It was brilliant presentation and wonderful Q&A section. Thank you for your experience, for sharing it with us. Thank you for your time.
Thank you very much for inviting me. Thank you.
Thank you. So we're moving forward to the next speaker. Шановні колеги,
Dear colleagues, we are very much grateful to Professor HUMAIDAN for his wonderful lecture. We have to say goodbye to him, and we're switching over to the next presentation. And also, that is the topic about the luteal phase support and optimization of luteal phase support area. I'm very happy to welcome Dr. MYROSLAVA VATSYK here with us. She's a famous speaker and lecturer in our community and who has prepared this presentation for us today, which is a logical continuation to our today's topic. Ms. MYROSLAVA, the floor is yours. We are waiting. Thank you, MYKOLA. Happy to see you all. In my presentation, I'm going to share my practical experience that I have, humble experience from my practice. Of course, I'm going to talk about luteal phase support. I have dramatically changed it over the last year, so I wanted to share this with you. So I will start right away from the first clinical case. Patient 29 years old, BMI 31, insulin resistance, MH 3.6, about 20 antral follicles in each side. Polyresistance tendency. In the majority of cycles, we can see anovulation. So stimulation protocol was started, and we expected more for follicles, but the patient has obesity, increased BMI, no high doses of follicle stimulator hormone because she was afraid of hyperstimulation hormone. 8 eggs were received, or oocytes, but 3 visually nice blastocysts were received as per patient wish. They were sent to genetic testing, and out of 3 embryos, we have received 2 healthy embryos. So in principle, it's quite a good result. The patient was treated, no complication, no hyperstimulation syndrome, and we received a healthy embryo that we started to get ready for transfer. Again, to focus your attention that the patient has obesity, increased body weight, even obesity, no ovulation. And just to continue with what Peter HUMAIDAN was telling us, and I respect him a lot, I love natural cycles as well, but the drawback of them, unfortunately, is that cannot be used in patients with anovulation, and we have about 40% of our patients with anovulation. So this patient is going to be offered artificial cycle preparation to trial transfer, fat transfer, and agonists of GnRH, estrogen, progesterone, vaginal was used here. And on the day of transfer, we looked at the levels of progesterone, and on transfer days, it was 7.3. And as you already know, who didn't know before what Peter told us, it's critically low progesterone level. And at that time, on the transfer day, I added oral progesterone as well, because the level of progesterone was low. And in principle, we received quite a good result. HCG 177, we were happy that we are getting a positive result, but unfortunately, 1 week later, I had a call from the patient to complain of discharge, and she was brought to ultrasonography. Clinically, we didn't confirm pregnancy. On the day of ultrasound, we checked HCG again. As you can see, it was low, so there was no pregnancy. Just to remind you that the patient still has 1 healthy embryo, so she decided to take a pause, and we started preparation for the second transfer in January 25, and the preparation was the same. I didn't change anything in the preparation for fat because of anovulation. On the day of transfer, we checked progesterone, and as you can see, it was 9.8, so closer to the lower cutoff level. But after going to the USA, and you mentioned, and Peter mentioned that Americans do it a little differently. So when I was at the Congress about how to prepare patients to fat, cycles, I heard for the first time that vaginal progesterone could be used twice, not risking adding oral progesterone. So I added vaginal progesterone twice, BID, Crenon, and in this patient we got positive HCG, no discharge and bleeding. So as of today, pregnancy is 32 weeks, so a successful pregnancy ongoing. So why I chose, on one hand, not a very complicated clinical case, but on the other hand, I would like to focus your attention that the patient, we looked at her embryos, so embryos were tested, and we understand that missed abortion couldn't happen due to low quality embryos because they're high quality. So the only reason, as I believe, it was increased body weight in this patient, increased BMI. And as long as we have a lot of patients like that, and not only in our country, but European, other adjacent countries, you can see on this map, the number of patients with excessive weight is increasing, and in all countries globally, each second patient from 25 to 44 years has excessive weight. Yeah, so that means those are our patients, because those are reproductive age patients coming to us. Usually, excessive weight and obesity is mentioned more often when there are some hormonal problems, and folliculogenesis is impaired, and that could lead to insulin resistance and polycystic ovary system and ovulation. But today I would like to focus on negative impact of excessive weight on endometrial receptivity, as long as both for endometrium, such changes will take place. Studies show that when BMI rises, the number of abortions increases to 11%, and cumulative live births decreases by 6.3%. And also embryo quality matters, but endometrial receptivity is going to be worse in such patients. The other study, quite recent one that was recently published, you can see implantation in patients with increased body weight decreases by 20%, clinical pregnancy by 19%, and live birth by 30%. What's interesting, that the number of miscarriages is going to be high in the first trimester and will be around 46%. And also there'll be miscarriage happening in the second trimester that will be about 17% of pregnancy. So in these patients, besides endometrial receptivity problems with increased BMI more than 30, and also with increased body weight more than 90 kilos, usually in 30% of such patients, progesterone levels is going to be less than 15 nanograms per ml, and subsequently that will lead to decreasing clinical values for our patients. Also, there were comparisons of patients with miscarriages with normal weight, increased weight, and obesity. And this slide shows that with normal weight, miscarriage percentage is around 11%, but for excessive weight, it's twice as high, and it's around 25%. So for such patients, we need to prepare them more thoroughly after transfer. What's interesting, PCOS, if a patient has a normal body weight, there is no significant impact of PCOS on changes in ART, but obesity per se will impact the outcomes of our programs. Why in such patients we also see that pharmacokinetics of drugs is changed? Because if a patient has obesity and she also has hepatosis, liver hepatosis, and high lipids, then if we use oral medications in such patients, They are actively metabolized by liver enzymes, and that is why their bioavailability can be lower. And respectively, in such patients, the difference between progesterone in blood, that's what Peter mentioned, is going to be around 25–40%.
So taking into the account that there is issue with bioavailability of the product per os, we need to prevail products of intravaginal route, because during the intravaginal route of administration, as a support of the lutein phase, the bioavailability is going to be 80% comparing with then 15 in case we talk about oral contraceptives. And also we are not going to have a liver involvement, which is going to decrease the amount of side effects. And in case we talk about the vaginal administration, we observe the direct involvement of endometrium inside the vagina. So we also talk about the progesterone evaluation in serum, but during the embryo transfer, we cannot identify the level of progesterone in the endometrium. So when we utilize Creon, we have evaluated the progesterone level in the endometrium, and it was proven that progesterone level in the endometrium and therapeutic dosages in endometrium are going to be higher in case you use vaginal gel, vaginal route, comparing with the case when we use oral products. So patients with excessive weight, the usage of vaginal progesterone is much more effective, and it also increases the implantation rate, biochemical pregnancy, clinical pregnancy, and also live birth rate. An interesting meta-analysis from 2002, when we have compared also 2022, when Crenon was compared with other products, and it was proven that clinical pregnancy in case of the vaginal Crenon is 87%, compared with 71% in case we use oral products. Crenon, 92% concentration stability in case we compare it with oral products, 63%, so 30% lower concentration in case we use oral administration in terms of endometrium. And also miscarriage risk is reduced 78% in case we use vaginal Crenon. So some of the key advantages which we are aware of: better bioavailability, no liver involvement, there is no influence of the enzyme of liver enzymes, and also direct delivery to the endometrium. Right now, I'm extremely happy that Peter HUMAIDAN has already mentioned about the endometriosis and adenomyosis, and I would like to switch to another clinical case which is much more complicated than the previous one, but also is extremely interesting. And in front of you, you have a relatively young patient, 35 years old, anti-mullin hormone 1.6. In our clinic, she got with the medical history of endometriosis of both ovaries, adenomyosis, external adenomyosis. There was the laparoscopic surgery in another clinic. During the war, she went abroad, and therefore repeated for multiple ovarian stimulations and repeated intracytoplasmic sperm injection. There were 2 transfers which were performed. 2 transfers in France were performed, but no pregnancy was achieved. Based on what patient has mentioned, the oocytes were not with the appropriate quality, and she addressed our clinic. First of all, this patient addressed not myself, and we had 3 stimulations which were performed by other healthcare professional in our clinic. Why I talk about this clinical case? Because even in our clinic, we also had the stimulation protocol, and during the first stimulation, we have received 12 oocytes and only 2 mature oocytes. And during the first stimulation, there was no embryo received. Then there was a second stimulation, overall stimulation. It was the 6th stimulation overall. Once again, it was in our clinic in another healthcare professional, and they received 12 12 oocytes, no embryo, and they're not frozen. Another interesting point that these cells, they're not mature, the follicles were monitored on a daily basis, and this is so specific, which was observed in Paris and also in our clinic. But this patient actually is going to try once again, another healthcare professional. They got one embryo, but it is BCC embryo, which was unable to be diagnosed. This kind of quality was not sufficient enough to test the quality. So then there was the fourth attempt. She visited me. For me, it was much easier, so to say, to perform the stimulation, because I have included the facts that this patient did not have enough oocytes, mature oocytes. And once again, I have monitored the patient on a daily basis. I have performed the punction on the size of the follicle, 23 milliliters, and out of 12 oocytes, we have received only 5 mature, and we got 3 embryos. And 3 embryos were sent to the genetic testing, and only 1 embryo was healthy. I'm going to remind you that this kind of patient had 2 embryo transfers which were performed in Paris. And because in our clinic this patient got just 1 embryo, BCC, and just 1 genetically healthy embryo, this patient was also preparing with the support therapy. So agonism of the gonadotropin hormone. Also, we have talked about the contraception products which were prescribed for adenomyosis. I have prescribed letrozole, and then Peter also has mentioned during the Q&A session that that is feasible to be done. I have prescribed letrozole, then estrogen products, and also Crinon products. And once again, after the ISRM 2024, according to my own patient's practice, I prescribed 2 Crinon, 1 in the morning and 1 in the evening, vaginally, and we got pregnancy. And she actually delivered. She wrote me from France, and she's extremely happy she got her child. Now let's make a step back to the theory. Peter HUMAIDAN has already mentioned that. Why does it happen like that among patients with endometriosis? Because patients with endometriosis and adenomyosis, these 2 diseases, they create the most difficult scenarios of the development of our ART program, because the chronic inflammation which happens in ovaries and also in uterine, and we've talked mostly about the luteal phase, the chronic endometrial inflammation, it increases pro-inflammatory cytokines in the endometrium, which creates a defect window of implantation. And of course, it leads to the decrease of biochemical clinical pregnancies, and also it increases the amount of miscarriages. Peter HUMAIDAN has mentioned about that, 34% and 44% in case we are going to include those facts, and also when we talk about the decreased low birth rates. What is the other reason? Peter HUMAIDAN has already mentioned that patients with endometriosis and adenomyosis, we have a progesterone resistance. And through which mechanisms does it happen? This is the key approach among patients with adenomyosis and endometriosis. It happens due to the fact that they have issues with gene expression. Progesterone receptor A and B ratio is achieved, imbalance in progesterone A, progesterone B ratio, where the progesterone A receptor are dominant, the amount of them is increased, the PRB expression is decreased, and that's how there is a decreased window of implantation. Despite that, among our patients with adenomyosis and endometriosis, they're going to have progesterone resistance. Yes, they're going to have an increased estrogen receptors, but also the implantation window defect, it also appears due to the fact of the decreased or reduced expression and modification of receptors. And decreased expression of key genes like HOXA10 and also LEAF. And all of that leads to the situation where the window for implantation is incorrect, it is narrowed, and these patients also require this more detailed approach to have the cryo transfer, frozen embryo transfer, FET, when we talk about these patients with endometriosis and adenomyosis. So, if those patients have progesterone resistance, they require higher dosages of progesterone. Peter has already mentioned that. And once again, I would like to vote for Crinon because Crinon, its bioavailability is around 92%. The direct vaginal administration, which leads to the direct uterine administration, it leads to the higher concentration, and also due to the unique progesterone release, it happens in a step-by-step fashion, and it happens during the 24 hours. So taking into the account the progesterone resistance, receptors of progesterone issues, and also decreased receptivity of endometrium due to the decreased markers, such patients require increased dosage of progesterone. It is also needed to be mentioned that patients with adenomyosis and endometriosis, quite often they have also myometrium peristaltics, myometrium movement, and myometrium movement disorder is going to be into the hyper movement, and also we are going to have the angiogenesis issues. That's why those patients, when the hypermotility of the uterine, we require to provide the antagonists of oxytocin receptors. In case we talk about the Crinon, I have already mentioned about the carboxyl base, polycarboxyl base, which allows us to have the direct involvement of the uterine with higher efficacy and higher bioavailability. But in case we are going to compare different forms of progesterone with Crinon, this kind of trials were also performed. And here you may see the bioavailability Crinon versus the Utrogestan versus endometrine and versus Cyclogest. And this is the comparative efficacy of these progesterone formations in terms of the luteal phase support. And it was not proven that Crinon is not effective. In fact, comparing with the other products, progesterone products, we do see higher efficacy and higher percentage of clinical pregnancies, and also the higher percentage of live birth rate in case we use vaginal Crinon. So, in terms of talking about the benefits of Crinon, I would like to mention, first of all, that for our patients it is extremely important. First of all, it's comfortable to intake, the comfort of administration. In case progesterone level, according to the reference, it might be used just once per day. It also provides the stable concentration of progesterone in uterus. It also directly gets into the uterus. It does not go through the liver, so it does not depend on the weight, and it does not depend on the enzymatic activity of the liver and insulin resistance. And it is not painful. Peter HUMAIDAN has already mentioned regarding the intramuscular injections. Our patients, and I'm going to tell that based on my experience, they do not love injections. And with huge burden, they agree even for stimulation with follicle-stimulating hormones. So usually, in case there is an opportunity to substitute intramuscular administration with some kind of other more comfortable vaginal administration, they usually agree on that happily. Despite that, my patients, when I have prescribed intramuscular products, progesterone products, I was hearing a lot of complaints about pain, that is painful, also about the allergic reactions, and also that is not comfortable to be used. That's why I recommend something that is useful for the patients and something which has evidence in terms of efficacy for our patients. Thanks so much for your attention. Thanks so much. That was a great talk. And while I'm waiting for the questions from the audience, I have a personal question from my side. That is the question, just maybe, you know, to consolidate everything that you have delivered. Could you tell me, based on these clinical cases which you have shown, you have standard support for simple patients, so to say, and you have more reinforced support for those patients which have endometriosis and adenomyosis. So in your system, what is the standard support and what is reinforced support, where patients require a little bit different support of the luteal phase? When you think about the resistance and change of the receptors sensitivity of endometrium to progesterone. Thanks so much for your question. Okay, take a look. I always tell you that we do not have simple patients. They do not happen with me, or complicated patients, because at any moment of time, simple patient transforms into a complicated one. That's the first point. Second point. In case patient has a good cycle, we do not have male infertility, so there is no female infertility. Patient is young. When we evaluate the progesterone level, we have good progesterone thresholds, as those who are recommended and were mentioned by Peter HUMAIDAN. We should not prescribe high dosages of progesterone. But in case we have patients with unsuccessful previous IRT, in case patients are aware of the adenomyosis, endometriosis, in case the previous investigations have already revealed the adenomyosis, as it was with the second patient, each patient sends me the level of progesterone on the day of the embryo transfer, and in case it is needed, I would like to augment it, and I provide it twice per day Crenon. And I would like to say honestly, dear MYKOLA, I have not made any kind of scientific calculations, but this year, when I have started to evaluate the progesterone level and I have started to increase the dosages of progesterone, the amount of miscarriages has decreased. So we have some results, practical results, something which I observe in my daily practice and my daily work. Yes, of course, that is something which is needed to be present based on what we have learned about the deficit of progesterone in case of the standard support. Last year we had more miscarriages. This year the results are making me happy. That's great when we may improve something. From the other point of view, I would like to say that in my personal practice, standard support has never been standard. We have never allowed ourselves to support luteal phase, what is considered as a standard support in Europe. We have never been limited by 400 milligrams of progesterone. We have always thought that this is not enough. Yes, each pregnancy is golden, and especially when our patients are covering it with their own costs out of pocket in most of the cases. That's something which I'd like to outline immediately. It's really hard to understand whether the patient is simple or whether the patient is complicated. For me, all of them are complicated because at any moment of time they might be transformed. Yes, you have understood my question. So a young woman with uncomplicated medical history without the male infertility, that is clear. Okay, we have some other questions.
More questions we are having: BMI and weight in general, and obesity. So how do they impact the strategy? Are there any cutoffs? And what do you do with that? So in other words, when and how. So we do understand that Crinon is a good instrument, but the algorithm, very interesting question as well. That is something that I always have a discussion about with endocrinologists. I'll explain why. Ideally, it's nice when a patient comes and with a BMI 25, well, maybe 27 at most. So, and that's if that is the cutoff, that is not quite obesity, but that's excessive weight. Would be nice cutoff for us. But we cannot, demand that from a patient to be within 2025. Probably it's not possible, because we are all different. It's not an ideal world, that we are living in. But when a patient comes to see an endocrinologist, and I always come, that she comes with a problem, with a problem in her head that there is obesity, and it's easy to urge the patient to lose weight because they realize the problem. But when it's not endocrinologists but reproductologists, they never consider obesity as a problem. And I just had a conversation with a patient, and with that stimulation, we have embryos. I did one embryo cryotransfer, and she has excessive weight. Her weight circumference more than 100. It's just for you to understand what's going on. She is 35, and she had a hypertensive attack after the transfer. She was writing to me about that, and I referred her to a GP because she had a high blood pressure for her age and everything. And GP said that she does not see any reasons for increased blood pressure because obesity cannot be the reason for that. So it's just the reproductologists and what they do. So she comes to me and she voiced that to me. And when she comes out, I'm saying that obesity, probably with regards to obesity, and when we are at the university, when also to decrease, to do something about hypertension, first you have to decrease weight, so that was number one, as we were taught. So 1 month passed and the patient comes to the visit, and when we started to talk what we are planning, and she is asking me when is the next transfer, I'm telling her that for ultrasonographically everything is okay. If you are ready, we can do the transfer. If you are not ready, and here she tells me she wants to lose weight. And of course, on that positive note, I supported her and we started to talk about ways how to lose weight. And I tell her that I will recommend the endocrinologist consultation. And here she tells me, I was afraid to tell you that I want to lose weight. And I was afraid to ask you about recommendations. On the other hand, I also realized, she says, that you couldn't tell me about losing weight. Because sometimes when you're talking about losing weight, she just changes the doctor or changes the clinic at all. So ideally, you ask about cutoff, 25, 27 would be ideal. But unfortunately, patients who come to see a reproductive specialist do not always want to follow recommendations. That's one thing, especially if those are older patients, they have no time for losing weight, and older patients are 70% of our community, our population. Yes, older ones, no time for losing weight, and also, well, maybe sometimes they just do not want or are afraid of something, so they cannot lose weight, all right? So if they cannot lose weight, so what's the strategy change with regards to luteal phase support? Again, higher doses of progesterone, and better to do it vaginally. I love the vaginal administration, route of administration, because if there are some lipid profile changes and the liver problems, I'm for vaginal. Of course. In principle, I believe that in this case, yes, oral is not very good in such cases. and I am on subcutaneous. We know how pleasant they are, so to say, pleasant. Sometimes we have to do that, but I also believe if we can use vaginal, of course it's better to use vaginal. A practical question. Whether you follow, because we've heard a lot about cutoffs, 10 nanograms per milliliter for progesterone, we heard about that. And by the way, quite often it's the day of transfer or 1 day before transfer or when. So when and how. So when, what is the cutoff and what do you do? If it's 10 or not 10 for you, and what do you do if it's lower? For me, it's 10, 2, again. So SRM recommendations are for me as well. That's the cutoff. I do it the day of transfer. Why? Because it's quite difficult for our patients to come numerous times to visit our clinic, considering the conditions that we are living in. So just to respect patient time, so they come for transfer, and day of transfer, we measure progesterone. At the end of the day, we have the results, and if it's necessary, next day we add medications if it's necessary again. And so what's the change in the strategy? So by 2 for Crenon, yes, Crenon 2, yes, for Crenon 2. If the patient used to have missed abortion or miscarriages, oral can be added, but after SRM information, Crenon twice, BID. So where we need higher progesterone, and we see fewer discharge and bleeding. So biochemical values are good, but if it's not coming to clinical pregnancy, this biochemical pregnancy is no good, no use neither to us nor the patient. And the last question that I have, and it would be nice at the end, it's less about progesterone, but still about progesterone and endometrium and luteal phase, personalized window for implantation, ARM. So whether you are thinking about that, what do you think about that? Interesting question. You know, always when a patient have used all they could, so ERA can be offered. Yes, ERA can be offered. I had a patient from Moldova with 11 transfer in Moldova, Romania, and Czech Republic, and it was not my recommendation, but she did the ERA test, and considering the results, we did the transfer. It was number 12 transfer, and this is the first pregnancy that we have achieved. So maybe it's like a psychological placebo pill effect here. I also believe in that too. I'm not going to recommend it if it's the first try, but if those are the patients who would like to try something else, why not? Because even such thing might have some psychological effect. Although we have different attitudes towards ERA test, different schools, some are pros, some pros, some cons, some do not recommend it. But I think that in cases like this patient, like transfer number 12, so it's quite okay. I agree with you wholeheartedly, you know. And there are some jokes about ART, whether it's a science or art. For young patients, it could be a science, but after 12 transfers, this is art. We don't know what will work. Of course, winners are not, you know, punished. We have a pregnancy, thanks God. I have no more questions, and timing-wise, it's time for us to finish, to complete our webinar. Thank you very much for your presentation, for wonderful Q&A session, and thank you for wonderful moderation. Thank you, Sona-Pharm, for wonderful organization, wonderful opportunity to meet online, at least online, to hear Mr. Peter HUMAIDAN, to hear from MYROSLAVA VATSYK. Thank you to Armed Forces of Ukraine for defending us. Thank you very much, and have a good night. Goodbye. Goodbye. All the best.